Thank you very much, Heidi. Thank you very much. My speciality was never fertility then, but I dealt with the older ladies as I got older. And if we could just start my slides. When given this topic, which is really confusing to many people, I decided that there were a couple of ways of tackling it. I could produce a whole lot of biochemistry and molecular medicine, and I could produce a whole lot of complicated, busy slides with many different meta-analysis and observational studies, but decided that maybe it was better to approach it in a way that's easy for us to explain to our patients, because that's where the problem lies when it comes to women who need hormone therapy but are fearful of breast cancer. And certainly, uncertainty is quite a valid emotion. I have no conflicts of interest. I have had help with slides from the International Menopause Society, and I looked first of all, what is the difference? Because around the world, we know that breast specialists, oncologists, and surgeons often have a slightly different view of hormone therapy than the gynecologist. And that is probably because 100% of your breast cancer patients have breast cancer, whereas we are dealing with a large range of women. And this is a slide which shows how long women are living now beyond the average age of menopause, which is 51. This is a slightly simplified version of that slide. And when you look at that rise from 51 going up to now about 83, as generalists, we have to deal with those women who are suffering from lack of estrogen, which results in many quality of life symptoms, hot flushes, night sweats, sleep disturbance, things that can really make their life miserable. Not only that, as they get older, they become more prone to other medical conditions, and breast cancer certainly being one of them. Now, where life is slightly easier for us than the breast specialist is we can counsel women about things that they can do, whereas once they arrive at you, they're still going to have these different complications, the quality of life ones and the medical things. And what can you do about it? Because we still can't find evidence that it's really a great idea to start hormone therapy. We're also aware that women are particularly fearful of breast cancer, as shown here that 39% of people think they will die of breast cancer, but in fact only 4%, and their heart is a far more dangerous organ. We are not unsympathetic to the fears and anxieties of both the patients, the oncologists, and the breast surgeons. And in fact, this is a painting commissioned by one of my patients who shows the doctor in the doorway about to run in and whip off the lady's right breast. This sort of slide is shown very often in talks to do with breast cancer. And it shows all the extra things besides age and genetics which can make you at high risk. And we've all seen this before, but the question is, what should we be telling those two people that are extra cancer patients before they start hormone therapy? So if you've got to go back to the experts, back in 1984, Dennis Davey gave a memorial lecture, and he was the father of menopausal care in South Africa, where he quoted the World Health Organization as saying they were uncertain about the link between hormones and breast cancer, but that until more information was available, we should be careful. He also, in the same lecture, quoted Nachtwalker and Gambrell, who said that estrogen and progesterone users in fact had a lower risk of breast cancer than non-users, and interestingly enough, that those on estrogen and progesterone had an even lower risk. Now we know things have changed because We've had the revised global consensus on menopausal therapy. And that first sentence I'll read because it's my exclamation mark. The risk of breast cancer in women over 50 associated with menopause and hormone therapy is a complex issue. Yeah, I think we all knew that. But they do say that it's low risk and that adding progesterone to estrogen increases the risk. We can't go through all the data from the last 30 years, but there are 2 or 3 recent publications. The one that caused the biggest stir was November 2019 in the Lancet by the Collaborative Group on Hormonal Factors in Breast Cancer. And this is what the authors said. This was a large meta-analysis of many studies that we were increasing the risk by 1 in 50, and of the last 20 million patients with breast cancer, 1 million were caused by us giving them hormone therapy. There are some criticisms of this, naturally not by the media. The media leapt on it immediately, much like they did in 2002 with the WHO trial, giving clearly false information, suggesting that you doubled your risk. So if you had a 10 out of 100 lifetime risk, it was now 20, because they don't understand statistics, as I also don't understand statistics. Some of the criticisms were that it was a meta-analysis of many studies, but significantly left out 2. One was the WHI, which is really the only proper randomized control study that's been done. The other was the E3N study from France, which was also important because it was one of the first studies which started to suggest that the progesterone that you use might make a difference. And that, I think, is going to become more and more important as we go ahead. You can't cherry pick from an article that you're criticizing, but something that was a little bit perhaps reassuring was they suggested that conjugated equine estrogen and estradiol had a similar effect on breast cancer, and there was insufficient data concerning transdermal estradiol. So up until now, everything which said if you add progesterone, and the progesterone is, if you're on conjugated equine estrogen, your risk of breast cancer is lower. And we couldn't really understand that. One of the explanations is because there's so many types of estrogen in conjugated equine estrogen that maybe some of them are acting a little bit like a SERM. Most of the study came from the Million Women's one, which had variable opinions about it when it came out, and also the General Practice Database in the UK. Furthermore, it didn't really cover currently recommended forms of hormone therapy. It didn't say anything about micronized progesterone or digesterone, and made no comparison with other benefits and long-term mortality. The Statistical Mathematical Risk Explanation Unit at Cambridge University interpreted that in this way, to try and make it easier for women. So they said that if you want combined estrogen and progesterone, out of 70 women, instead of having 4 cases of breast cancer, you'd have 5. And if you want estrogen only, pushed it up from 13 to 14 out of 200, which obviously are quite small numbers. The other, this actually is the one from the General Practice Database in the UK. It's an observational study, and if you summarize it, this is what they said: 22 extra cases in 10,000, 5 if you're on combined past user, and if you're on estrogen only 3 extra cases. There was no increase in risk of death, and they started saying that norethisterone, in other words, the testosterone-based progesterones, are the ones that are most likely to be harmful. and diasterosterone being a little lower risk. Now, in terms of our local products, you shouldn't mention local products, but people will come to you and say, I'm on this or on that. The one with the norepinephrine, the most common one used is Activol or trisequins or the patches, and the one with the diasterosterone is called Famostin. Could we go to the next one, thanks. Then a large review of the Women's Health Initiative came out, Chablovsky, and basically the conclusion that they made was much what we expected, that they had a huge amount of people in the WHO study, that they once again found that estrogen only did not create breast risk, and once you added medroxyprogesterone acetate, you did increase the risk. And I'm sorry I haven't got a pointer, but if you look at those, the middle two dotted lines are the placebo. And the darker one goes with the estrogen only, showing risk of breast cancer over time, and the yellow one goes with the combination. So it does show that there's quite a significant reduction in risk with estrogen only, but not when you add the progesterone. And this applies to conjugated equine estrogen, which we have the most information about. This just gives some sort of idea about mortality and morbidity in people on hormone therapy. We've left in the breast cancer there, higher in people on progesterone, which is once again medroxyprogesterone acetate, and lower in estrogen only. And also a number of other health benefits, except when it comes to oral hormone therapy with progesterone, that you lose some of the cardiac benefits and you do have a slightly increased risk of deep vein thrombosis. This is very much like the slide I showed earlier, just giving some of the risk factors. We know we don't win with lifestyle advice. I mean, it's just the worst thing. I always say to patients, I've got really bad news for you. The treatment is diet and exercise. And they don't listen to that. But the interesting thing about this, where you see the general population, if you're using transdermal estradiol and micronized progesterone, the risk of breast cancer is very much less than expected with the others, and much the same as with the general population. That goes under the name of Femigel and Nutrigestan. This just gives a little comparison between those two big studies with risk, and you can see that the big follow-up, 18 years, many people, they're still showing a reduced risk when on estrogen only. This just shows mortality and the fact that it is better if you're going to take hormone therapy to start young. And we knew that all the time, actually, and WHO confirmed that, especially when it came to heart disease and dementia. This is a similar study. I'd never quite understood the title, but it does show a little bit in favor of estrogen only compared to placebo. This becomes more and more important, and Philip has already alluded to Angelina Jolie, in that premature ovarian failure, which was previously a medical condition or surgically induced because of cancer or whatever, is now becoming more common with risk-reducing salpingo-oophorectomy. And we must be aware that those patients are at risk. When it comes to death, it's largely due to heart disease, depression, Parkinson's disease, dementia, and cognitive impairment. So that we mustn't look at timing when it comes to hormone therapy in the women with what we used to call premature menopause for whatever reason, because they are at risk. And my view is that you keep using hormone replacement therapy for them. You can use the pill, whatever, until the natural age of menopause. Because what we're looking at really when we talk about hormone therapy and cancer is extending somebody's estrogen life well beyond that average age of 51. I just wanted to say very briefly a little bit about local estrogen. Now this is interesting in that it shows the level of serum estradiol, which is the threshold for when people will start getting genitourinary symptoms. That number there isn't what we use. You multiply it by 3.6, you get picomoles per liter, and that would be about 160. So when you're getting below that level, that's when women start getting vaginal and urinary symptoms. And if you can avoid it, you don't want to push their levels up in the postmenopausal state unless they need it for vasomotor symptoms. So if you look at what's available for us, if you take the average woman 2 years after menopause, her estradiol levels will be 3 times between 8 and 11. And then the serum levels using the vaginal ring, which we don't have here at the moment, the 10 microgram vaginal tablet gets it up to well below postmenopausal levels. The Premarin cream is difficult to measure because it contains so many different things, and they use surrogate measures like FSH. This just gives you a little idea of the level with the 10 microgram vaginal tablet, which I think is the one which most oncologists seem to prefer. And it shows that after the first week, the levels stay well below the postmenopausal levels. The one that I haven't mentioned because it keeps coming on and off the market is Synapause, otherwise estriol, which because it has about a 10 times less affinity with estrogen receptors, is possibly one of the local estrogens of choice, particularly if you're looking at somebody who perhaps had endometrial cancer. If you want to see about local estrogen, read the editorial in the Menopause Volume 21, where they ask why should the product labeling be changed on the vaginal estrogen, because we've all read it and all the old ladies have come to us and said, I'm not going to put this stuff in my vagina, it's going to give me Alzheimer's disease. So read that. I think there's some optimism for the future in that we are learning all the time. There's evidence of safety of transdermal estrogen in terms of DVT and stroke. It's almost certain that there's no breast cancer risk for local estrogen. Progestins are decidedly the villains. And I remember Professor Dennis Davey, back when Alan and I were working in his clinic, saying progesterone is poison. And it wasn't so much to do with the breast, but due to the side effects, the sort of premenstrual side effects, and also the fact that it negated the benefits that estrogen gave for cardiovascular system. So we're looking at different progesterones. The testosterone derivatives are thought to be a bit worse. The Mirena, we've just heard there's a big question mark against. And then one day we might get the TSEC, which is conjugated equine estrogen with the SERM basodoxaphene. And one would hope that would have almost like a tamoxifen effect on the breast. Just for your interest, responses come from around the world. Alan and I have been very privileged to meet all the leading people in the menopause world, whether North America, Europe, whatever. And what I'm very happy to say is most of them are now women. They used to be grey-haired old men like us. And they will always respond with something which just says what you're going to tell your patients. You're going to say you must use the hormones for a good reason, you must discuss all the pros and cons, you must get the dose right, and also speak to them about some of the side benefits more than just the vasomotor symptoms. Thank you very much.
Thank you very much, Professor Roos. That was a very informative talk. I don't know if there are any questions from the floor. You have a very quiet audience today. Does no one want to interact with us? Can I ask a question?
Yeah.
But it's not necessarily related to just breast cancer. I'm interested because I have quite a few breast cancer patients who have come and have been on hormone replacement therapy, as I have quite a few that have never been on hormone replacement therapy. I always wonder, to my mind, how long should patients stay on it? So, I know you said the duration depends on the symptoms, but I've had patients who refuse to get off the hormone replacement therapy 20 years down the line because it keeps their skin nice and everything in place.
And the
cognitive function.
Yeah.
So what is kind of the advice that you give on that?
There is no rule. Internationally, all the menopause societies in their various agreements have said so long as you're assessing the patient properly and they're using it for the right reason and they feel they need it, then they can continue virtually for as long as they like. You have to say that one must think that if you're on a combined estrogen and progesterone and you take it for 20 years, you're perhaps a little bit more at risk of breast cancer than if you take it for 5 years. But we see many people who decide to stop, and I often say to people at 60, take a break and see how you feel. And they come back with strange things, like they'll come back and say, I just want it because I'm not sleeping. Or I want to go back on it because I'm getting joint pains. And things that you don't really think about that much when you first start them on it for hot flushes. So there is no rule amongst all the experts. And these are trustworthy experts. I mean, there's a lot of who and hawing around, are we in the pockets of the pharmaceuticals?
I'm sure you're not.
And the last 3 out of 4 presidents of the North American Menopause Society have been women. One who has herself a breast survivor. The last president of the International Menopause Society is a woman. And so many of them. And that's what I think Alan and I worked very hard at, to stop the South African Menopause Society just being 12 old men. Because nobody's interested in us. I mean,
we've got a question. Irene, would you like to go ahead and ask your question? Irene Goodinghouse.
Well, thanks again for a fantastic talk. I just wanted to make a personal observation, actually, not even ask a question, and just share that my mother was on HRT from the time she went into menopause in her early 50s until she developed breast cancer at the age of 79. And every now and then I'd say to her, don't you think you should stop, Mum? And she said, absolutely not. It keeps me sane. And when she developed her breast cancer at the age of 79 and died rapidly afterwards from complications of treatment, just before she died, she still said she had absolutely no regrets whatsoever. And I always try and remember that when counseling patients, that, as long as your patient is aware of the risks, if it's worth it for them, it's worth it for them. And one can't just take it away from people. So thank you very much for providing women like my mum with 30 years of great life.
Thanks, Irene.
That's great to hear, because it does put our trust back into HRT. Sorry, and then Prof. Alberstein also just wants to make a comment.
Following on what Pete was saying, Professor Davey, who's the doyen in our lives, who taught us all, wrote a paper about 3 years ago at almost age 90. And he said, if you look at hormone therapy, to answer the question, how long, when to adjust, he said, between age 50 and 60, the benefits far outweigh any risks. Between 60 and 70, your benefits and risks are in equipoise. There's got to be a reason. There's got to be that benefit from quality of life and other pathologies you want to prevent. And after 70, there's got to be a really, really good reason to stay on it. And I agree with Pete that there are a handful of patients who believe that their quality of life is enhanced by being on hormone therapy.
Thank you. Yes, we've definitely met those patients, and I think that's also why what Irene stated is so important. I think that's a valuable point.